Thank you very much, and I'd like to welcome everyone to the today's webinar entitled "Increasing Detection and Improving Outcomes in Hereditary Transthyretin Amyloid Cardiomyopathy." Very excited to present and discuss this important topic with everyone. This program is accredited both for physicians, nurses, and PAs. The activity is supported by an independent medical grant from Alnylam in the United States. These are my disclosures. I have grants from several pharmaceutical companies, including your government, and i3 Health has mitigated all relevant financial relationships. So today our objectives are to evaluate the clinical features and diagnostic tests that can enable a timely and early identification of patients with hereditary ATTR and ATTR-CM, assess the safety and efficacy of current and emerging therapies, and think about treatment selection considerations for individual patients with hereditary ATTR-CM or mixed phenotypes. So maybe we'll start with a few questions. This is the first one. TTR variants are inherited in which of the following patterns? Autosomal recessive, dominant, mitochondrial inheritance, or X-linked? Okay, interesting. The correct answer is autosomal dominant. Patients just need to have one copy of this allele to cause disease. So everyone has a 50-50 chance of inheritance from an affected first-degree relative. Next question. In the US, what is the most common TTR variant that is seen that almost exclusively affects individuals of West African ancestry? And there are various choices there. Val30Met, THR60 ALA, Val122 ILE, PHE64 LU, or HIS88 ARG. Good. Most people got it right. It's the Val122 ILE variant, as we'll talk about. Next question is a non-biopsy diagnosis of ATTR variant CM can be made without the need for any other blood test by simply ordering a PYP scan. Is this statement true or false? Good. Most people got it correct. You can't diagnose cardiac amyloid simply by a PYP scan. It needs to be coupled with an assessment for monoclonal proteins. And our final question is, all the following are possible therapies for TTR amyloidosis that operate through a mechanism of stabilization, stabilizing the TTR tetramer, except which of the following? Is that diflunisal, Acoramidis, Vutrisiran, or Tafamidis? And that is correct. Vutrisiran is a silencer. So great. So with that background, the pathogenesis of TTR amyloidosis has been well worked out. For those of you who don't know, TTR, or transthyretin, is also known as a prealbumin, is a tetrameric protein that's manufactured predominantly in the liver. There's a little bit made in the choroid plexus and the retinal pigment epithelium. And this protein exists as a tetrameric protein, individual monomers linked together. And through two different pathways, either a pathway of cleavage that can sometimes occur, for example, in people with aortic stenosis, or through a protein instability that occurs in the inheritance of a variant in TTR, the protein breaks apart into pieces. Those pieces agglomerate and form amyloid fibrils that can deposit in the heart, causing restrictive cardiomyopathy, heart failure, conduction disease, and arrhythmias. And the protein also has a predilection for liking the nervous system or nerves as well. So here's again a picture of the tetrameric protein misfolding into monomers and forming amyloid fibrils. When it deposits in the heart, we call that ATTR cardiomyopathy. When it deposits in the nerves, we call that ATTR polyneuropathy. And as you can see, they have a very different spectrum of age of onset, where neuropathic variants usually affect people of younger age and cardiac variants usually affect people of older age. There are greater than 130 known amyloidogenic variants in the transthyretin protein. In addition to those variants, there are also a concomitant phenomenon with aging that the protein becomes unstable. And so again, we can develop either a sensory motor polyneuropathy or a restrictive cardiomyopathy, depending upon which tissue is affected. So-called familial amyloid polyneuropathy, typically the classic variant is the Val30Met, in which methionine replaces valine at the 30th position, is a common variant seen in Portugal, Sweden, and Japan, affects people at a relatively young age, and is a relatively rare condition. And then there's familial amyloid cardiomyopathy, so-called hereditary disease. V122I is the major variant. In fact, in the US, about 3.4% of individuals who are of African ancestry carry or self-identified as Black carry this variant. And so there could be as many as 120,000 patients in the US who have disease, though there are over 1.5 million carriers. And then there's so-called age-related or wild-type TTR that we're not talking about today, but is the dominant form of cardiac amyloidosis seen because of the aging of the population. So why is transthyretin a protein pre-albumin amyloidogenic? Well, as you can see, each segment of the protein, each monomer has a lot of beta-pleated sheets, these running back and forth that allow the protein to, if you will, stack once it dissociates into monomers on each other. As I mentioned, there are multiple variants that can contribute to instability, and the pathogenesis in variant disease is related to instability in the protein from the variants, but it's not entirely clear why wild-type disease occurs. That's not as well worked out. The pathophysiology is kind of shown here, in which you can see a very thick-walled ventricle, which the ventricular chamber capacitance, if you will, or size is very small, and the atrium are quite large, and there's a marked increase in the wall thickness. And this results in a physiology that's shown here, in which this is normal. ESPVR is the contractility of the heart, EDPVR is the filling. In amyloidosis, there's an increase or upward shift in the end diastolic pressure-volume relationship, and as a result, stroke volume at a normal filling pressure is markedly impaired. The body doesn't like that. The low stroke volume wants a better cardiac output, so it increases the pressure inside the left ventricle to try to normalize or increase the stroke volume, though it still remains less than normal. And often these patients have heart failure or preserved EF and a relatively normal or low blood pressure. TTR was sequenced many, many years ago in 1974 by Robert Canfield and colleagues at Columbia. This is the genetic sequence of it. It's a 127 amino acid protein. And I just circled many of the areas where there are hotspots in the protein where there are different variants in TTR. Something that leads to confusion is the naming of TTR variants. The standard way we used to name TTR variants involves the start of the normal amino acid followed by its position in the mature protein, and then the variant in the amino acid. So methionine is the variant that replaces valine at the 30th position. Alanine replaces threonine at the 60th position. Isoleucine replaces valine at the 122nd position. All that made sense. Then genetics labs started to add a 20 amino acid signal peptide. And so the naming convention got confusing, in which all of these numbers increased by 20 points. So V122I is the same as P.Val142ILE because you're counting the 20 amino acid signal peptide. This is a list of all of the different variants that have been known to date. As I mentioned, more than 130 with both the conventional nomenclature and the more up-to-dated one that uses the 20 amino acid peptide signal. So just to review, there are other forms of cardiac amyloid that certainly mimic variant TTR. There's AL amyloidosis or light chain amyloidosis, where the precursor protein is the immunoglobulin light chain. This is a disease that affects equally males and females and affects people of kind of middle age. The heart is affected in certainly 60, 70, or maybe even 80% of patients. Similarly, the kidneys can be affected in 2/3, and so cardiac and renal involvement can occur in about 1/3 of patients. A multisystemic disease with peripheral autonomic neuropathy and or liver involvement about 15%. And this disease is highly malignant because it's an infiltrative toxic myopathy, and the treatment is anti-plasma cell therapy. And God forbid you have advanced Mayo stage 4 cardiac amyloidosis from AL, you could have a pretty malignant or poor prognosis. Wild-type TTR, again, not the focus of today's discussion, is a disorder predominantly of older adult males. This may be an ascertainment issue, why men are seemingly diagnosed more frequently than women. The precursor protein is transthyretin, and there's no known genetic cause. There's a whole host of orthopedic manifestations that occur in individuals that are warning signs, particularly carpal tunnel and lumbar spinal stenosis. And prognosis is markedly improving, but also dependent upon the stage. And both variant and wild-type TTR can be treated with either silencers or stabilizers. Variant TTR, though, again, is inherited in autosomal dominant fashion. There's a mutation in TTR there is a slight male predominance, and the particular mutation derives when the disease develops. The heart is involved in most of the cases at some point in time, though there is a significant peripheral and autonomic neuropathy in many patients that can precede cardiac involvement. And again, this is treated with both stabilizers and silencers, though silencers are the preferred treatment usually for variant disease. AL amyloidosis is really a rare disease. Only about 4,000 new cases incident per year, and most have cardiac involvement, as I mentioned. Variant TTR is probably not so rare, I would say, in which, as I mentioned, 4% of African Americans are carriers of the variant V122I, and depending upon its penetrance, there could be a wide range of affected patients in the United States. And wild type TTR, I would say, is bordering on not even a rare disease, given the fastest growing segment in the worldwide population are people over the age of 75 or 80. So we're seeing a marked increase in this diagnosis. I have to have a high index of suspicion to diagnose a variant TTR amyloidosis or any form of amyloid. Obviously, patients can have symptoms of heart failure or concomitant arrhythmias, either atrial fibrillation, non-sustained VT on monitoring, or bradyarrhythmias, or need a pacemaker. As I mentioned, there are a whole host of orthopedic manifestations: carpal tunnel, lumbar spinal stenosis, Popeye sign or a biceps tendon rupture, joint replacement, knee, hip, or shoulder, and trigger fingers. And the neuropathy is very classic in a lot of variant TTR amyloid, including an autonomic neuropathy that could result in orthostatic hypotension, alternating constipation and diarrhea, and weight loss from malabsorption and gut motility disorder, or bowel or bladder or erectile dysfunction from the autonomic issues. Transthyretin, as I mentioned, an interesting protein that's 127 amino acids. Its job is to transport thyroid hormone or thyroxine and vitamin A or retinol. It's a minor carrier of thyroxine, and it's the only carrier of vitamin A in the body. The predominant features we see, for example, with the Val30Met or Portuguese mutation, are particularly a peripheral and autonomic neuropathy initially, cardiomyopathy later. The Val122 ILE variant, common in Blacks in the United States, predominantly a cardiomyopathy with minor neuropathy, and the so-called Appalachian variant, common in north areas of Ireland, if you will, causing a mixed phenotype with a cardiomyopathy and both a peripheral and autonomic neuropathy. Again, the most common variant in the US is the so-called Val122 ILE variant. This is the number of people who live in the United States. These are the number who are self-identified as Black, and 3.5% of this population would give us about 1.3 million carriers of V122I. How many of these individuals develop disease is a question. And again, inheritance is autosomal dominant, but as we'll point out, it's important to test people as they get older because this has an age-dependent penetrance. Pathological penetrance when you're over the age of 65 in studies have been 100%. So on autopsy series, people who carry this variant have amyloid in their heart. But clinical penetrance is unknown. In a recent study that we conducted called SCAN-NP using nuclear scintigraphy, we found that more than half of the patients had demonstrable amyloid on PYP scanning in their heart with this particular variant. So penetrance probably higher than we thought. So often nowadays, clinicians are being asked to see patients, noting that, for example, I got a genetic test. My dad had amyloid, and so I want to get evaluated. And this is a 52-year-old patient we're talking about who's Irish, comes for consultation. His father unfortunately died of variant cardiac amyloidosis, presumably from the THR-60 ALA variant that's common in people of Irish descent. And so he underwent testing and had that particular variant. And the question is, how do you manage this particular patient and all the patients who have variant disease? So I would suggest a kind of a four-step process. First, what is the variant? And if you know the variant, then you can find out from tables what kind of phenotype it will present with, cardiac, neurologic, or mixed. So when is it known to penetrate? At what age? Second is in the patient, when now that you've prepared to see them, you take a history and a physical exam, trying to determine, do they have signs and symptoms of amyloid? Did it manifest in other individuals at a particular age that can refine the age of onset in this particular family? And you want to do targeted neurologic and cardiac examinations, even if they don't have signs and symptoms, to see if they have a phenotype. And then subsequently, you do obtain necessary, more sophisticated testing, and they may come to a diagnosis at this point in time, and you institute therapy. And if not, you're continuing to follow these patients on the long term, monitoring them for the development of penetrant disease and the need for targeted therapy. So again, step one, what is the variant? How does it manifest? And what is the penetrance and at what age? This is a fan diagram created by my colleague, rest in peace, Claudio Rapezzi, and he described that Val30 Met, early onset seen in Portugal, has predominant neurological phenotype. Late onset has a mixed phenotype, and other variants, as you can see, have a wide spectrum, with the cardiac-related variants over here. THR60 ALA, the patient we're interested in, has a predominant cardiac, but also kind of a neurological phenotype. The V122I is much more often cardiac. This is the LEU111 MET mutation seen in Danish individuals, and the I68L seen in people of Italian descent. Interestingly, if you look at the age at which people have onset of disease, this is a graph, you get the sense that wild type patients seen here have the latest onset with an average age of diagnosis about 75. This is the median. Whereas you can see V122I patients over here are slightly younger, not 75, but about 70. But you can see that wild type, cardiac phenotype, mixed phenotype, and neurologic have different ages of onset. And so you're going to be looking in younger individuals for more neurological phenotype than you would in an older adult, and vice versa. And their particular mutations have very different ages of onset. And in the ACC guideline that has been published, there's a table that talks about penetrance of disease and typical age of onset. So for example, in the individual we're talking about, usually it penetrates after the age of 50, causes a cardiac more than a neuropathic, but both of these phenotypes. And again, penetrance is quite high in this particular individual. For V122I, we've known that it's not completely penetrant, as I said. By echo, it was only 10% in a study by AREC, but as I said, in a study we recently conducted, it's much higher by PYP scanning and 100% penetrant pathologically. Irrespective of whether it shows up on an echo, a pyrophosphate scan, or a biopsy, it's been associated with a marked increased risk of heart failure. So it's clinically, if you will, penetrating and causing an increased risk for individuals, which is why we're concerned about it. And as you can see, it has a kind of an age-dependent penetrance. It takes many years for it to show up. These are data from several large cohort studies in which it shows here that it increases in carriers the risk of heart failure mortality, CV mortality, and all-cause mortality. And this particular variant seems to show up the most common in the US sometime in this study after the age of 70. But more recent data in a large pooled study seems to suggest that even at the age of 50 years of age, heart failure hospitalizations, maybe 60 to 65 all-cause death, and similarly, heart failure hospitalizations or death tend to increase around that age. And so we urge people to kind of get tested about 10 years before the predicted age of disease onset in those particular tables. So if you have a penetrance of, say, at 75, you want to test someone starting around 65. Step two is now that you know what the variant is and you prepare to see the patient, you want to examine them, do a 3-generational family history, and do targeted examination neurologically. As I mentioned, the cardiac phenotype is predominant in V122I, so they may have subtle neurological symptoms. They could have orthopedic manifestations, autonomic, but cardiac is the predominant. Neuropathic, obviously, neuropathic symptoms are predominant, and cardiac symptoms tend to occur less frequently and more often conduction disease and later. And the patient we're talking about requires both an extensive cardiac and neurologic exam to evaluate for this particular condition. Third is after the examination, you need to follow up with standardized testing. We often do an EKG and an echo, cardiac biomarkers, and then depending upon their need and the particular variant, PYP and MRI, and maybe even go on to a particular biopsy. So again, cardiac testing, EKG and echo, particularly with strain, is important. MRI is quite useful to look for a phenotype and the structure and function of the heart and delayed enhancement. Nuclear scintigraphy, when coupled with assessment for monoclonal proteins, can rule out AL amyloid and diagnose TTR. So quite a definitive test, again, without monoclonal proteins being present. And we found cardiac biomarkers to be quite helpful, especially if they're normal. They have a very high negative predictive value, and you may be able to obviate some ongoing testing, and they're a lot simpler and less costly. And then neurologists perform a careful neurologic exam in which they measure something called the neurologic impairment score that's been used in clinical trials to measure the severity of the neuropathy. There are a bunch of questionnaires, and then there's EMG and skin testing and autonomic testing that can be performed to comprehensively assess a patient who has a variant that's associated with a neurological phenotype to determine whether or not they have any evidence of neurological manifestations of this particular condition. Clearly requires a multidisciplinary team. So you've done step 1, 2, and 3, and at some point in time, you may, through these testing, establish the diagnosis, in which case you would institute therapy. If you didn't establish the diagnosis, again, the patients need to continue with careful follow-up, because while they don't have evidence of disease at present, we said the penetrance could be high. They could develop the disease over the subsequent years, and they come back for ongoing evaluation and testing. How often should we test patients? Well, no one knows. What it's been suggested by individuals is, again, to determine the predicted age of disease onset of the particular variant, and then start testing people about 10 years prior with serial studies. And there's even trials ongoing now for people in this range who don't have disease that are part of prevention. So again, step 4 is to foster this long-term relationship, either through the need to institute treatment because you've identified the condition, neuropathic or cardiac amyloidosis from a variant, or just to follow up the patients. We should spend some time today talking about the emergence of a highly effective therapy for variant TTR amyloid, and importantly to note that all the therapies that have been developed are much more effective when instituted early in the course of the disease, which is why we spend some time talking about how to find the disease as early as possible. I would note that when you're genetically testing individuals, you're going to be much more fruitful to test people who are siblings of the patients that you identified, not their children, because the children are less likely to have disease. So again, TTR is a protein predominantly produced in the liver. Here's its tetrameric structure, falling apart into pieces and forming the amyloid fibrils. There are strategies to knock down or silence TTR. Gene editing is experimental and in trials, but there are agents that have been approved: Vutrisiran, Patisiran, and Eneplanatersen, all silencers. The only one that's approved for cardiac disease in isolation is Vutrisiran at this point, whereas Patisiran and Eneplanatersen are approved for neuropathy with or without a cardiomyopathy, but you have to have a neuropathy. There are drugs that stabilize the tetramer, Tafamidis and Acoramidis, or off-label diflunisal. They fit in between the dimer-dimer interface and stabilize TTR. And then there is experimental drugs that are being worked on to try to activate macrophages and remove amyloid. These are not yet clinically available. So what's clinically available is knockdown, silencing, and stabilization. This is the concept behind TTR stabilization, a small oligomer or drug that can basically prevent the protein from breaking apart into pieces. A very elegant work originally done by Jeff Kelly, who invented Tafamidis. And Tafamidis was studied in the ATTR-ACT trial that we published several years ago. You can see here it binding in the dimer interface, and it was very impressive reduction in mortality with a number needed to treat about 7.5 patients to prevent death, and a significant reduction in heart failure hospitalizations and cardiovascular hospitalizations with an NNT number needed to treat of 4 to prevent one heart failure hospitalization over 12 months. These are the data from the original trial. We had 2 doses of tafamidis, 20 and 80 milligrams, that were pooled compared to placebo. 60% of the patients received tafamidis in this trial, 40% received placebo. Patients, like in all trials, are older adult, predominantly males. We were pretty successful at recruiting variant patients. So this is 24% of the population was variant as opposed to here showing 76 wild type. The EF was about 48, markedly increased wall thickness, low stroke volume. So their stroke volume index to body size is way less than 35 mLs per meter squared, very low strain patterns, high sensitive troponin, very high NT-proBNPs. And amazingly, patients are only NYHA class 2. And I think the reason they're not that symptomatic is this is a very slowly progressive disease despite this severe phenotype. More recent data that have come out of the trial, which I think emphasizes the importance of early diagnosis. So these are the original trial and then a long-term extension. And these are what we call NAC stage 1 patients or early patients. And you can see they had a 57% lower chance of mortality. These are the curves for NAC stage 2 patients, a mortality benefit, but it took longer to accrue. 49%. And these were the NAC stage 3 patients, which took even longer for the curves to separate. And again, much lower chance of a mortality benefit. So I would say earlier institution of therapy, all therapies, Tafamidis, Acoramidis, and Vutrisiran, the better they work. In our center, these are just data looking at over the years, 2001 to 2013, we only saw 100 patients with amyloid. From 2017 to 2021, we saw 215. Now we see 250 new patients a year, so lots of new patients. And you can see very few of them now need a biopsy, where early on everyone needed an endomyocardial biopsy. We have very few advanced patients. In gray here, this is a staging system that we developed, that these are advanced patients, so we're finding people earlier, and we're instituting disease-modifying therapy. And all of these, increased awareness, early diagnosis, and effective therapy, have led to markedly improved outcomes. So you can see the median survival early on, prior to 2013, was about 2.5 years, and now we haven't even reached median survival. It's probably out to 7 years. So amazing improvements in how people are doing with modern therapies. The ATTRv-CM trial, looking at Acoramidis, very similar age and gender to ATTRACT, a little less African Americans and a little less variant patients enrolled. They were actually much healthier with more class 2 and class 1 than less class 3, and the NT-proBNP was lower. And this drug was markedly effective. They used a similar approach statistically called the Finkelstein-Schoenfeld approach, in which you compare each patient to each other on active therapy versus placebo to see, God forbid, who died first, and then who was, if there was a tie, then who was hospitalized more frequently, and then NT-proBNP, and then 6-minute hall walk. But looking at the first two hierarchies, which made up a majority of, if you will, the wins in this comparison, the win ratio was highly significant, showing that Acoramidis was better. And Acoramidis is a molecule that was designed to mimic the T119M variant. That's a variant that causes stabilization of the TTR protein, and so may be a more complete stabilizer than Tafamidis. These are data from that trial, basically showing who was randomized and showing the key outcomes. And you can see that time to first event occurred pretty early, because this was a population who was not very ill. And so earlier disease, the drugs have a better effect quicker, if you will. It's not to mean they don't help patients who have more advanced disease, but we really want to try to find people as early as possible. And there was impressive reductions in all-cause mortality and first CV hospitalization, recurrent events, and CV hospitalizations. It reached a number needed to treat of 5 with a 50% reduction. Moving on to silencing. Well, we know that in other forms of amyloid, one called AA amyloid, that almost always affects the kidney before the heart, but is due to a chronic inflammatory condition like Crohn's disease or familial Mediterranean fever. The serum amyloid A concentration, the higher it is, the worse the patient does. Said another way, if you can decrease the inflammation and lower the protein, the better the outcomes of the patient. And the same is true for AL amyloid, where anti-plasma cell or chemotherapy can achieve what we call a complete response and basically stop the plasma cell from making the bad protein. Those patients who have a CR or normalization of their light chains do much better than those who don't have a clinical response. So this led us to hypothesize that shutting off transthyretin by silencing mechanisms would be effective. And there are 3 approaches to knocking down or silencing TTR. We can use a small interfering RNA, Vutrisiran. We can use antisense like a or we can use gene editing. This is, again, experimental. So these were the first trials, not in patients with cardiomyopathy, but in variant patients with amyloid polyneuropathy. Many of them did have a cardiomyopathy. And what they proved in these studies that led to the approval of patisiran and inotersen, published in 2018 in the New England Journal, is that patients unfortunately assigned to placebo had marked increases in their neurologic impairment score, which means their neurological symptoms and signs were getting much worse very quickly. This disease progresses like 15 to 20 times faster than diabetic neuropathy. And so, really a rapidly progressive neuropathy, and patients randomly received patisiran had a stabilization and maybe some improvement in neuropathy. And the same was true for inotersen. Inotersen's been removed from the market because there's a new compound called a plenitersen, and this was approved with a REMS procedure, and at least in the US, it's no longer available. But both effective agents, and prove the hypothesis that silencing TTR production would be a good therapy. So people then developed next generation agents. Vutrisiran, patisiran, the one I mentioned previously, was an intravenous medicine dosed every 3 weeks, so 17 times a year with pre-medicines. Vutrisiran is dosed subcutaneously only 4 times a year, every 3 months, with no pre-medicines. And you can see here, it led to a similar reduction in TTR or pre-albumin levels in patients as patisiran, and again had a marked improvement in the neurologic impairment score, with placebo patients doing worse and active drug therapy patients doing better. And this is the plenitersen data in the neurotransform, again, lowering TTR levels, and again, compared to historical placebo-controlled who had worsening of disease, stabilization of the neuropathy. Both of these agents are on the market and approved for variant disease and polyneuropathy. But subsequently, we tested vutrisiran not only in neuropathy patients, but in cardiomyopathy patients. And these are data that was recently published by Mariana Fontana in the New England Journal last year. Very impressive 28% risk reduction of all-cause mortality and CV hospitalizations in patients assigned to receive vutrisiran. And in this population on study 654, there was a large group of patients who were only receiving vutrisiran, but there was an even larger group, you can see, or who were receiving baseline therapy with Tafamidis. So this is a very contemporary cohort of patients, not only well treated, but some of them on combination, if you will, therapy, and many of them on MRAs and SGLT2 inhibitors. And you can see in the overall and monotherapy population, robust reductions in hard endpoints, including recurrent CV events and all-cause mortality. These are the Kaplan-Meier curves from those the trial that I mentioned, looking at the overall and monotherapy population and the time to events, and the lack of heterogeneity across many pre-specified endpoints, showing that essentially vutrisiran was better than placebo. Similarly, we looked in this trial at heart failure severity. I would point out that this trial included mainly class 2 patients, several but few class 1. And the class 3 patients did not have, if you will, NAC stage 3, so not very severe NYHA class 3. But across the spectrum of NYHA class or NT-proBNP in the overall or monotherapy population, I think you can see the point estimates and hazard ratios all favor vutrisiran, and there was no heterogeneity of the effect on either all-cause mortality and recurrent events or all-cause mortality, suggesting a robust effect. What are the issues in prescribing these agents? Well, I have to say they're unbelievably well tolerated, and the side effects are pretty minimal. So starting with the first one, Tafamidis, there were side effects during the trial were similar to placebo. There are substrates of BRCP that can increase the exposure of Tafamidis. And so if you're giving a statin, a rosuvastatin, or a high dose, atorvastatin, you need to be a little bit careful. There have been rare case reports of myositis. And so we often switch patients on statins, but there's no necessary concomitant medicine to be given. Acoramidis in the package label had a diarrhea and some increased abdominal pain noted, slightly more than placebo, pretty minimal. There was no known concomitant medicines, and you have to avoid concomitant use with these kind of agents because they can affect the drug levels. And vutrisiran has sometimes a little arthralgias, some very rare injection site reactions, just an alcohol swab and a sub-Q injection. There are no known drug interactions, but because you're silencing TTR, you have no way to transport vitamin A. You have to take a vitamin A supplement, standard recommended daily allowance, 950 micrograms or 3,000 international units a day. With the advent of several effective therapies for transthyretin amyloidosis, there have been a whole host of emerging questions, which I wish I could give you definitive answers to. I don't think anyone knows. So, which therapy should you pick first? Should you be switching people from one therapy to another? Should you ever stop therapy, especially in someone who's markedly advancing and progressing, because the therapy is not that effective in very advanced disease? There's no head-to-head data. We don't know if we should combine treatments. We don't know really if someone has demonstrable disease but is truly asymptomatic. Should we start treatment? I would lean toward doing it, but you have to remember cost is quite high. But this is a disease in which what patients lose, they don't regain. There's a huge financial burden and potential toxicity either to an individual patient or the healthcare system, given the cost of these therapies. So in an attempt to try to answer some of these questions, I'm going to show you some data. These were published in a recent review we wrote in JACC Heart Failure. And this is the Tafamidis, Acoramidis, and Vutrisiran, the respective trials, and the number of patients were in each of the trials. It's important to note the era of the trial. So very hard to compare patients a decade ago with patients now. The age has stayed relatively stable. And as I mentioned, we've been less successful at enrolling, if you will, variant patients over time, which is not a good thing. But we've done a great job at reducing mortality, even in the placebo arm. And the placebo event rate is even lower. And why did we do this? Because we're enrolling earlier and earlier stage patients, as you can see, lower NT-proBNP over time, and way more class 1 and 2 patients, which is all great. And that results in data like this. And again, this graph is really only to compare, right, the placebo arm. So here's the ATTR-ACT placebo arm. Here's in green the attribute placebo arm, and here's the HELIOS-B. So with no therapy, everything's getting better. And the reason it's getting better is because we've identified people earlier at an earlier stage of disease, and we need to continue to do that. So how do I approach a patient when I'm talking about this? I try to have a process in clinic, which takes a while, of what we call shared decision making. And I jokingly say what shared decision making is not. It is not, I decided what to do and then I told the patient what I was going to do, but rather it's a collaborative process where the provider and the patient work together to discuss the nuances, consider the patient's values, preference, and what they want in order to arrive at an appropriate treatment decision that is focused on their individual circumstances. In the absence of really high quality data at this point, I think this is a critical process. So what topics have come up in shared decision making? Well, honestly, most importantly, patients are talking to me a lot about how is these drugs administered. Oh, one I can get orally. I don't like shots, or I don't mind to come for shots 4 times a year. Do I want to take Tafamidis once a day? Acoramidis is 2 pills in the morning and at night. Or do I want to get a shot? Again, once a month is a Penetrance, not approved for cardiomyopathy in isolation, and Vutrisiran every 3 months. And, where do I get this? Do I have to come to a clinic, and so forth? So that's one discussion. And people, believe it or not, have pretty strong feelings. For individuals who have variant disease, there's pretty good data to say that TTR is more unstable in the presence of a variant. It falls apart quicker. And so, in such patients, many of us lead toward maybe some of the newer agents, that is Acoramidis and or Vutrisiran. And in those with a neuropathy, either peripheral or autonomic, there's pretty good data to suggest that silencers may be the preferred agent. And again, for some patients, it's just about maintaining access and rather than quibbling over which drug to use, making sure they have ongoing unfettered access to disease-modifying therapy based on their insurance and so forth. We have become very interested in this disease now that we have effective therapy at monitoring what I call disease progression, or hopefully maybe disease regression at some point in time. And there are different domains that you could focus on in clinic, obviously clinical domains in which we look at how many times someone, God forbid, is hospitalized, or whether or not we need to use more diuretics. They have worsening New York heart class, or how many days alive they spent out of the hospital. There are functional measures, including 6-minute hall walk, the short physical performance battery, frailty measures, or exercise testing. laboratory testing, including biomarker staging systems, renal function, maybe pre-albumin levels, which is TTR. They obviously go up with stabilizers, they go down with silencers. There are a whole host of patient-reported outcomes you could use serially over time. You could look at electrocardiographic issues, and it's important to look for new AFib, progressive conduction disease, or God forbid, the need for pacemaker, and a whole interest in looking at imaging variables on either echo, MRI, or PET. The caution I would just say is just because people can progress in one of these domains, the question you have to ask yourself is this all related to an abnormality in TTR biology? Meaning, we all as clinicians want to help our patients. Just because someone's getting worse doesn't necessarily mean more or new drug therapy is going to be better and stave them off. We don't know that. And the reason I mention that is we have pretty good data from examples in Alzheimer's disease, CNS amyloid deposits, in which patients up here are their brains are saturated with amyloid, but they still have progressive neurocognitive dysfunction. This is not driven by necessarily more amyloid. So there are a lot of downstream mechanisms that could lead to worsening heart failure that might not be related to TTR biology. It's incredibly important in this disease to have a multidisciplinary team. Ideally, you'd have this list minimally and potentially many others, but I don't think you can manage this disease without access to a cardiologist, a neurologist, and a pathologist. Genetic counselors are incredibly important. So we know quite a bit, as I mentioned, about this particular condition, its inheritance pattern, and a lot of that you can look up in the tables that I mentioned and really inform patients yourself, reserving the difficult questions for the counselors if needed. So I think we can wrap up and conclude today by noting that basic scientists have done a really fantastic job at elucidating, if you will, the biological mechanisms of a transthyretin amyloidosis. And that underlying basic biology, in which we know that we have a tetramer in the setting of variants, it breaks apart into monomers and forms amyloid fibrils, has essentially informed and led to the effective therapies that we've been able to develop. And credit is really due to them. We have not had really many negative trials in amyloid, and that's not because we're great clinical trialists. It's really because basic scientists have invented very effective and translational biologists, very effective therapies, but because they knew what the disease is caused by and how it works. All the approved therapies really are very effective, and I think the key for clinicians is not to quibble about which one, but to focus on timely identification of an affected individual, get the drug as fast as you can, and administer it because they all work very well and they're effective disease-modifying therapy. Many amyloid experts believe that silencing in patients with cardiac phenotypes who have variant disease and mixed, so mixed, if you will, neuropathy, cardiomyopathy, silencers are kind of the preferred agents because separate randomized trials have shown essentially efficacy in both cohorts of patients. But wouldn't be dogmatic about it. And for patients who have variant disease and a mixed phenotype, you really need to, if you're in the cardiology realm, which I am, co-manage with an expert neurologist. I have a fantastic colleague, Dr. Thomas Brannigan here, who's the world's expert in this particular condition. And that's critically important for evaluating the efficacy of drugs and seeing how patients hopefully stabilize and don't progress in order to ensure their continued access to therapy. I would just conclude that the references that led to this presentation are all enumerated here and will be available for all those who are interested in. And so thanks for your time and attention, and I'll open it up to questions. What is the best genetic test for detecting variants? Can a PCP order this? So there are many laboratories that you can use. I don't have any particular one. There's Precision Genetics, there's Ambry and Vitae. I'm sure there are others. Ironically, genetic testing is usually provided by some of the companies that make amyloid products free of charge. So certainly a PCP could reach out to any of the companies and get free testing for their patients. It's actually a very, as I mentioned, small gene. It has 4 introns to sequence. Doesn't take the laboratory very long. all the variants are well known, and so the reports don't come back. Don't be scared, like other genetic panels in which you've ordered for cardiomyopathy, 92 different genes, and you could end up with 6 variants of unknown significance. We pretty much know whether something's a variant that's disease causing or not in this condition. So I think a PCP could order this. Obviously, some of the information I've given you today, I hope provides you with a framework for ordering such testing. All of the amyloid centers in the world are happy to assist you and help you. And obviously, if you found a patient who you were concerned and had variant disease, weren't sure what to do, you could reach out to myself or any of the amyloid experts. I would point out, again, that genetic testing is probably the most fruitful in siblings of a proband. So if you have a 75-year-old who has V122I, testing their children if they're 40 is okay, but they're probably not going to have disease at the age of 40 because there's an age-dependent penetrance. So it's most important to test the siblings, older adults first, not necessarily the children. And certainly, I don't think there's any reason to test people in their teenage years with this disease, because it doesn't, TTR variants don't manifest usually before the age of 25 or 30. Next question was, how long have patients been treated with each of these agents? That is a great question, by the way. I'm a little old-fashioned. You're always skeptical. I mean, I've treated patients with these agents for a decade or longer. I mean, I have patients who've been on Tafamidis for more than a decade, because we did, the original trials. In fact, from ATTR-ACT, it started in 2013. I had more than 30 people enrolled, and I still have 3 subjects who are still more than 12, 15 years later taking Tafamidis. So it looks like long-term safety is quite good. They don't need a drug holiday ever. In fact, this is not a disease in which you want to stop the therapy. It's lifelong. These aren't therapies that, especially the stabilizers, that I'd panic over if you missed a dose. So, patients sometimes go on a trip and they forgot their medicines or something. The protein doesn't immediately fall apart and start depositing in your heart next week. And so you kind of explain to people it's a slowly progressive disease. We want people to be adherent. And most of these patients are, but I don't think you need to be crazed about, missing a single dose or stacking up on a pill. I don't encourage people to take more. The half-life, for example, of Tafamidis, free salt is like 51 hours. So if you missed a dose, you'd still have it in your bloodstream for several days. Should all patients with heart failure be tested? Well, that's a good question. I don't think all patients with heart failure, but there are, we didn't talk about this, certainly individuals in which you take a medical history that you could be suspicious of. So for variant disease in the United States, I mentioned 2 genetic backgrounds or ethnic backgrounds. If you're African American or Black, or you're Afro-Caribbean, you could have V122I. Certainly, if you have that with a family history of a cardiomyopathy and a neuropathy, I'd definitely be testing patients. The orthopedic manifestations tend to occur more often in wild type, but do occur in variant disease to quite a bit of degree. And so we often ask clinicians to take an orthopedic history. That is, have you had lumbar spinal stenosis, carpal tunnel surgery, especially bilaterally, joint replacements, hip, shoulder, knee, a quadriceps tendon tear, or a biceps tendon tear, which if you see someone in your office who has a preserved DF, heart failure, a thick-walled heart, and you take off their shirt and they have a Popeye sign in which their biceps tendon bunches up, that person has amyloid until proven otherwise. It's highly suspicious. And again, I'm all for genetic testing, but I want to remind you that majority of patients who have amyloid have wild type disease. And so I would be cautious about only doing genetic testing and saying, oh, you don't have amyloid, because they could have a normal TTR gene sequence and still have the so-called senile cardiac amyloid or age-related or wild type TTR amyloid, because that's what exists in the wild. It's not a variant disease. So I hope that's clear. I definitely endorse genetic testing, but it should be in the cascade. Which advances are you most excited to come in the next few years? Yeah, another great question. I think patients, because you should always learn from your patients. They're absolutely wonderful people, really fantastic to take care of them. I also point out that because of the variant nature and the inheritance, you can, if you're a subspecialist, become like a family doctor again, taking care of family members, which is quite nice. Patients are most excited about the anti-amyloid therapies that could remove amyloid from their organs. Obviously, especially people who are diagnosed with intermediate or more advanced disease, these therapies that we have prevent new amyloid but don't work on removing existing. So that's what patients are excited about. And there are several compounds that are in late phase clinical trials. And if you have people who are interested in, feel free to refer them for clinical trial enrollment. And then people are pretty excited about gene editing. That is, CRISPR-based therapy. There's a phase 3 trial now ongoing in which you could knock out TTR, reduce serum TTR levels quite effectively by more than 90%, at least in the phase 1 trial that was published in the New England Journal. And you don't need repeated treatments. It's permanent. Obviously, you need to continue to take vitamin A. So that's pretty exciting. And then I would say on the diagnostic front, there are imaging techniques that are quite exciting. We're using PYP imaging or technetium, which could also be done with HMDP or in Europe, DBD, imaging. They're pretty great and highly specific, but we've learned that they're maybe not the most sensitive. And so PET scanning studies are ongoing now, which may ultimately in the next year or two replace PYP as the upfront imaging agent to diagnose cardiac amyloid. There's a imaging agent called evuzametide. Again, amazingly effective therapies, Vutrisiran for mixed phenotypes we emphasized today. All the therapies much better if you can find someone earlier. So I encourage all the clinicians out there to always think to yourself, could this be amyloid? Once you start thinking about it in your differential, you won't ignore it, and you will make a diagnosis much earlier. The patient will be forever grateful to you, and you will have a tremendous impact on their longevity, quality, and quantity of their life. Is there ever a serum concentration to promote dissociation? So interestingly, TTR blood testing, if you will, or pre-albumin blood testing, which is what you order in the lab, in patients with variant disease, pre-albumin levels are often below normal. And that's not a malnutrition issue, even when they just have no phenotype. And we think that's because the serological test for pre-albumin measures tetrameric or intact TTR. It doesn't measure the monomers or oligomers. And so imagine TTR levels are between 20 and 40. Imagine your level is normally 30, but half of your protein is falling apart because you have a variant, you'll be down to 15. And one of the clues, can't substitute for a genetic test, is you see a new patient, you check their cardiac biomarkers, you're lining them up to get genetic testing and a PYP scan, and the pre-albumin level will come back at 18. That's very suggestive of a variant in TTR. And often you can corroborate that with the genetic testing that'll come back a few weeks later. So, and as I mentioned, TTR levels, we follow them in our amyloid program with Vutrisiran, a silencer. They will go down and be suppressed by 80, 85, 90%. And with a stabilizer, they'll go up. And when you use the combination, not that that's recommended or approved, but the silencer wins, and usually the values are still markedly low. So the concomitant use of a stabilizer doesn't change the serum TTR levels. Oh, I think we're at the witching hour. So again, I thank everyone for your time and attention. I hope this was useful, and I'm really happy to see many people who are interested in this particular condition because we've made a tremendous amount of progress, but it needs to be disseminated more widely so all the individuals affected can benefit.